So you have water there. That's good.
Water, I have coffee.
All right, you guys are all set.
Hi, hello everyone. My name is Katerina Dounavi, and we are today hosting at the Center for Behaviour Analysis Nursel Ozkan Gonzalez. We are delighted to have her with us today, present on bowel movement difficulties. Nursel studied in the US, special education and behavior analysis. She then moved back to France in 2014 and has been supporting families there since then. Nursel, I will pass on to you now. Enjoy the seminars, the webinar today, and you can write questions on the right side.
Right, and I'm going to try to keep with the questions, but I also saw that the people could ask questions while on the webinar, and then we can respond them later, I believe. So
we can do that at the end, definitely, yes.
Okay.
So we can. We will have some time at the end. I think that's probably better. Okay, so we will at the very end. I will come back on camera and help with that a bit.
Okay,
so we will organize that. Thank you.
Thank you so much, Katerina. So hi, everybody. Thank you very much for your interest for this very interesting topic. My name is Nursel Gonzalez. I'm a BCBA who has been working in France since 2013 now. And before that, I was working in the United States. Today, we will be talking about bowel movement difficulties encountered by children with and without autism and evidence-based treatment options for toilet training. So, as you may know, since the success of the rapid toilet training of Azrin and Fox, a large body of behavioral research is available on toilet training. And in some cases, when behavior analysts work directly with families, we can actually be the frontline professionals on the matter. I had a high interest in toilet training since the beginning of my professional life. I was very interested in rapid toilet training and how reinforcement contingencies could actually help children achieve toilet training without actually with positive interventions and with little stress to the families. But at some point, some karma happened and or some attraction law, and more families started soliciting me. I will answer the questions. Actually, I put the handouts. I believe you should be able to go to the handouts button and download the presentation. And another document that I will tell you what it is all about at the end of the presentation. So I'll go back. So families started soliciting me for toilet training issues, and I realized how little I knew about toilet training and how complex it may become. And today, the purpose of my presentation is sharing information, tools, and resources for a better understanding and management of bowel movement difficulties in our roles as behavior analysts that I got to discover throughout my practice until now. So the presentation and the mentioned resources, so most of them are referenced, are accessed freely online. So most of the time I also put the link to access the whole article or a specific resources under each slide. For the ones who are here, you can download the handouts by clicking on the handout button. And for the ones that are going to be watching this presentation later on, you can just shoot me an email and request the PDF that I can send with pleasure. So what are the basic components of toilet training when we look at the Azrin and Fox rapid toilet training procedure? There's hydration, scheduled toilet sittings, reinforcement contingencies for successful eliminations, pairing procedure, reinforcement contingencies for independent toileting skills, feeding procedure, and consequences for accidents. So let's talk about some behaviors. This table was taken from a systematic review where they actually looked at the literature and put a list of defecation-specific behaviors that were identified. The ones that actually we're not talking about when we are on the behavioral basics that we know around toilet training. I'm sure many of you have already heard parents talking about children manifesting pain or fear when defecation, the ones that are withholding stool or who refuses to defecate in toilet, the one that refuses to sit on the toilet or manifest fear or anxiety, retentive posturing, the children who ask or wait for a preferred diaper to poop in it and never in the toilets, the ones that refuses or who are reluctant to use school toilet or any other toilet than home, the ones who defecate while hiding or who have prolonged straining times, the one that denies incontinence, who doesn't manifest sensation of urge, or who defecates in a specific place other than the toilet, the ones who are not upset by soiling, who have fear for wiping, flushing the toilet, the smell of feces, and the feces itself. So the behaviors that I highlighted in yellow, I highlighted in yellow because most of these behaviors are actually the ones that we may hear the most often, and most of these behavior may actually be associated with constipation. So now we're going to talk about constipation a little bit to know more about how it can occur, to know more about constipation in a medical point of view and the treatment options. And then we will go over what behavioral treatment strategies we can incorporate within a toilet training program. So constipation can be categorized in two different categories. Organic constipation or functional constipation. Organic constipation, it is when the underlying physiological cause is identified. We know why the constipation is here, medically speaking. Functional constipation, it's when a physical or physiological cause is not identified. And actually, there is no specific medical reason who can explain why the child or the person is constipated or have functional constipation. So obviously, when it's an organic constipation, the medical field will take care of it. But what do we do when it's a functional constipation? So let's look at the prevalence of functional constipation. Sorry, I think I'm going to turn off the chat because I'm getting very distracted by it. So if for the questions, please use the question button and we can see it at some point. I can take breaks to look at them. Let me see. Are you sure you want to leave this event? No. I'm just gonna, how is diagnosed constipation? We're gonna talk all about that, but please write your questions on the question box instead of the chat box, because I am not gonna be looking at the chat box anymore. So the prevalence of functional constipation actually is quite high in different parts of the world. So when we look at different studies in North and South America, including infants and adults, 23% of can have functional constipation. In Europe, the numbers are between 0.7 to 12%. In Asia, 0.5 to 29%. So the question could be, why is there so much variability in the prevalence data? One reason is that the criteria for functional constipation may differ from one study to another, and also the population that has been studied may differ. But what we know is that Actually, functional constipation is one of the most common conditions in childhood, according to a report that was published by the Department of Health of England. And those results and those information.
I'm in the middle of an event and.
Sorry? Did someone speak?
I was not muted. I'm sorry.
Okay. So the prevalence of functional constipation is high across different continents and countries. Also, the prevalence data in autism, the studies with children with autism shows that 9 to 70% of children with ASD may actually have functional constipation. So I'm going to share some more data about different aspects of functional constipation. This was a study on the age of onset of functional constipation. There was 538 participants on this study, and the results showed that actually the age of onset of constipation is between 2 and 3 years old. So this is important information because actually that's the time when we start toilet training, and there are chances that the child actually may develop functional constipation while we are entering toilet training or introducing it. Solid line on this graphic shows the number of participants who had an age of onset according to the line here. So you can see that at 2 years of age is actually when most of the participants had an age of onset. The dashed lines on the other side shows when presentation was made, and on the medical study, presentation really means when the child was referred to a specialist. And when we say specialist, we're talking about a pediatrician gastroenterologist, not a pediatrician or a physician or primary care provider. And what we see is this gap between the solid line and the dashed line shows the time gap between age of onset and age of presentation. And what we can see is that the younger is the child, the larger is the gap between age of onset and presentation. And the older the child gets, the time gap between age of onset and age of presentation is decreasing. One of the hypotheses is that maybe in younger ages, it is more accepted that the child has some sort of constipation or swallowing problems. And while the child gets older, it becomes less socially accepted. And maybe parents are looking for medical help a little sooner when the child is older. Also, what we know is that what this research was saying is that before the age of presentation, even if the child has already seen a pediatrician or a primary care physician, the constipation is not treated effectively. Therefore, we need to be very careful on the red flags about functional constipation. And I hope this presentation will give you a lot of information about how to capture red flags rapidly. So what are the causes of functional constipation? When it's organic constipation, the causes are organic. There's either a medical situation or a surgical situation that's underlying the constipation, the functional constipation. And obviously, those are the doctor's job to look for what organic causes could explain the functional constipation. Also, there could be genetic factors. It is showed scientifically that there is a positive family history usually involved. Also, some prescription drugs can induce constipation. And when we're working with children who are taking prescription drugs frequently, daily, or occasionally, we should take notes of those medications and look for their side effects to see if it's not a drug-induced constipation. Also, some self-medication, over-the-counter drugs could induce constipation. So for families who are giving some sort of supplements, it's good to ask the question and get the information to check on the side effects of supplements that the child is taking. And then there could be many environmental factors. I note down some of them on the slide, but toilet training issues may cause functional constipation, withholding and stool retention, which is something we're going to talk about in depth in future slides. Changes in diet or dietary factors can cause functional constipation. Changes in routine, lack of physical activity, birth of sibling, transition to a new school, or distressing emotions could also cause functional constipation. So now, what are the criteria to really put a diagnostic of constipation? So those are medical criteria. So professionals in the medical field will use those criteria to identify if the child has functional constipation or not. The criteria vary a little bit between infants and toddlers up to 4 years old, and for children and adolescents who are 4 years and older. We're going to look for at least 2 of the following symptoms present for at least 1 month for 4 years old, and for older children, those 2 symptoms should also be present, but also present at least once per week. The symptoms are 2 or less stools per week, a history of retentive posturing, history of painful or hard bowel movements, history of large diameter stool, presence of a large fecal mass in the rectum. Some additional criteria could be considered for children who already are toilet trained. So at least 1 episode per week of incontinence after the acquisition of toileting skills, and history of large diameter stools that can obstruct the toilet. The symptoms are very similar for older kids, and I'm not gonna spend more time on this slide because there is another definition of constipation that could be more interesting in our practices. So there are some red flags. The red flags in autism and ADHD are that children with ASD and ADHD have an increased risk of functional constipation. And constipation may be missed in 1/3 of children with autism if only clinical criteria that I showed on the previous slide alone are used to make a diagnosis. So we're not going to use the room for criteria. Constipation also is difficult to diagnose early in ASD, as most of the existing clinical practice guidelines are not designed to routinely interrogate and capture data relevant to GI issues in these children. So that brings us to a more conventional definition of constipation. And the definition is, constipation has been defined as reduced frequency, underlined because that's important, and or difficulty in defecation for 2 weeks or more, arbitrarily defined as less than 3 times per week. Today, scientifically, there is not an optimal frequency of defecation for a human being. Everyone has a different type of metabolism, has a different speed. Some people can have 3 bowel movements and healthy bowel movements per week and be completely healthy, while some other can have 2 bowel movements a day and be completely healthy as well. So that's very important to take baseline data before starting, if there are no constipation already identified, for example, to really watch for reduced frequency and monitor our treatment plan to not be on any situation where the toilet training program may actually induce constipation because some parameters were wrong. Potential risks if occasional constipation lasts too long. Let's say a child has occasional constipation that was never addressed, and that this occasional constipation becomes more of a routine thing. And when it lasts at least 3 months, then the diagnostic will change. Now, medically speaking, it will be called a chronic constipation. Chronic constipation that lasts too long as well will lead to encopresis or fecal incontinence. We're going to define that in a little bit. And the consequences of chronic constipation or encopresis is that the child or the person will have recurrent episodes of pain, disruption in family life, social life, and at school. It could develop anxiety and depression. It can create social stigma and decrease quality of life of the child, but also of the family. And usually when we listen to testimonials of parents who have children who suffer with chronic constipation for too long, Usually it sounds like a very, very painful daily situation that they are handling. So what is encopresis? So on my slides, encopresis and fecal incontinence or soiling, they're all used synonymally. So fecal incontinence or encopresis is defined as the loss of stools in places inappropriate to the social context at least once per month in children with a developmental age of younger than 4 years old. Now, what do we know about fecal incontinence? In 80% of children with fecal incontinence, this symptom is associated with functional constipation. So see how everything is starting to get linked up. A video on YouTube that's also child-friendly if you ever want to show a child how fecal incontinence can be induced by constipation. What happens is that there is stool that starts accumulating in the rectum and the colon, and more fresh stool is coming up, building up on that stool that's already there and stuck. And what's can happen is that the freshly coming stool, which is a less harder, can leak out and cause fecal incontinence. And in 20% of children with functional incontinence, there are no signs of fecal retention. So there's no constipation, there's no underlying causes, and the child doesn't have continence or bowel movement controls. And that is classified as functional non-retentive fecal incontinence. So I forgot to say, I'm very sorry because I'm going to be using a lot of medical terms. It's not to make the presentation more difficult to understand, even though it does naturally. It's also to give you the right terms when you are in front of a situation where the parent is giving you information to know what details you need to get as information and what name can you put to a situation to then later look for possible solutions on different resources. So encopresis also could be categorized in two categories. So primary encopresis, where it refers to soiling in a person who has never attained bowel control, and secondary encopresis, where it refers to soiling after successfully attaining toilet control. So we'll do a fast recap, and then I'm going to look at your questions before we move on to the next thematic. Fast recap. So now we know functional constipation is a common condition in childhood. The average age of onset of functional constipation is between 2 and 3 years, and the majority of children have onset before school age. Occasional constipation can become chronic constipation if it lasts more than 3 months, and chronic constipation may result in encopresis or functional fecal incontinence. Referring to a conventional definition of constipation may be more adequate to use in order to decrease the risks of a late referral. And what may be reported as soiling can actually be associated with functional constipation. That's one detail I forgot to give when we talked about fecal incontinence. Sometimes when parents actually contact us or me and are talking about a child who has difficulties achieving bowel movement control, and they're gonna be actually reporting a diarrhea episode, and they're gonna say, my child has frequent diarrheas. And when we look at the history and analyze the current situation, it actually is not diarrhea, but it's a functional incontinence that's induced by constipation. So it's really important to highlight that information. So I will go to your questions now. Oh, okay. I don't know about the certification confirmation. The copy of the PowerPoint, there should be a handouts button where you can download it right now. Have to find a certified special gastro doctor in ASD to make the diagnosis. In France, it's really rare to have special doctors about these questions. Yes, and not only in France, it's actually a common problem in many countries. You can send me an email and tell me where you're located, and I can try to see if I can put you in touch with a gastroenterologist who would be willing to give you an appointment. But otherwise, you can just go to a pediatrician gastroenterologist. Usually what we do, I don't know if your child is already, if he has any professionals, but if he does already work with a behavior analyst or a psychologist who could make a report, that's what I usually do. I never send the parents alone when I know and I have some historical facts about a difficult situation around constipation. I make a report and put all the facts and data so the situation of the family can be taken a little more seriously. How is the word difficulty defined? Difficulty could be the child showing pain, the child also having some retentive posturing, could be some signs of difficulty to defecate. Chris, could you respond to the people who are trying to download the handout, because I don't know how this looks like on the other side. When an older child holds bowel movements and has only ever had them in nappies, and as a result will also often refuse to use the bathroom for urination, would you focus strategies on bowel movements to get these consistent first? If the child has symptoms of constipation or bowel movement difficulties, yes, we should definitely first manage bowel movement, and it should be addressed until we have soft stools regularly. And once we know that the child can have can defecate without pain and regularly, we can start working on other things. But I think I'm lacking also some information. So what we can do is, we can come back to that question once I finish my presentation, because there are some indications about the behavioral treatment options on the future slides. Slide, how is the word difficulty defined? Can functional turn to organic if doctors miss helping with functional constipation? Not really, because what can happen is that doctors can miss an organic cause at the first point, and then maybe come back to an organic cause that they missed to identify earlier. But when we have a diagnostic of functional constipation, that's what it is, unless you develop a medical condition that comes and add to your current situation, which can create a new organic cause that didn't exist previously. Okay. Perfect. So now we'll talk about the behaviors. So the stool toileting refusal behavior, which when we look at the definition, it's a very observable and measurable behavior, and stool withholding, which could also be observable and measurable, but we cannot take those behaviors as just behaviors, because they are also associated with specific medical conditions. There can be, sometimes they're not, but most of the times they are. So stool toileting refusal and stool retention. I actually created a new color code with my highlights. So all those behaviors on this table that are highlighted in yellow are considered stool toileting refusal, and the green ones can be considered stool retention. So what is stool toileting refusal? Stool toileting refusal, it occurs when children refuse to defecate in toilet, even though they accept to urinate in toilet, so they have urinary voiding control, for a period longer than 1 month after achieving bladder control. So the child has already mastered voiding in the toilet, everything is successful for urination for 1 month, but after 1 month, we still don't have a poo in the toilet. We do have some, but it's never in the toilet. The behavioral indicators, usually the child may ask for a diaper each time he needs to defecate. And once parents give the diaper, he will go and defecate in the diaper. The child may defecate in his clothes. That's also considered stool toileting refusal. And the child may defecate anywhere but the toilet, with or without his clothes on. Sometimes some children can do it in the bathroom or in other places at home, sometimes in specific situation, or sometimes in very different situation, as long as it's not in the toilet. So what we know about stool toileting refusal, during the toilet training process, as many as 1 in 5 children will go through a period of stool toileting refusal. Sometimes it can be very quick and go away, and sometimes it could actually be a problem that's long-lasting that wasn't identified. And children with stool toileting refusal train significantly later than their peers and have a higher incidence of stool withholding, which I'm going to define later on, requiring physician intervention, and are at great risk for primary encopresis. So we cannot look at it just as a behavior. We need to know what this behavior could be associated with. So there was a research, a prospective longitudinal study with 380 children between 17 and 19 months of age. And of the children, according to the results, who experienced both stool toileting refusal and hard bowel movements, 93.5% demonstrated constipation before the onset of the stool toileting refusal. The fact that hard bowel movements frequently occur before the onset of STR suggests that for many of these children, constipation is a chronic problem that is not being treated effectively or sometimes not even identified. So hard bowel movements and painful defecation are factors that potentially contribute to the STR, and for the majority of children are not caused solely by the STR behavior. So it is very important that when we're talking about stool toileting refusal, to get all historical information to go and check the red flags. Now we'll talk about the second behavior, the stool retention, which can also be called stool withholding. So stool retention is when the child withholds bowel movements. The retentive behavior can sometimes be captured, and it can sometimes also be misinterpreted as training. So in infants and toddlers, the retentive behavior can be standing on toes, extending legs, or rocking back and forth, preventing anal relaxation. Those are typical features of stool withholding behavior. And some children may hide in a corner, standing stiffly or squatting, or holding on to a furniture. Usually it would be a chair, putting and standing on their toes. And we could, if they're wearing a tight pants, we could see some tightening of the buttocks while they're doing stool withholding. So stool withholding can also be associated with constipation, but not only. So what happens when it's associated with constipation is that the child has a painful stool episode. He's constipated. Defecation hurts. So the child becomes fearful of repeating the experience. And then the next time he has the urge to defecate, he withholds bowel movements. And then child continues to have hard, painful stools because withholding actually causes constipation and hard bowel movements. And that becomes a vicious circle. But some other reasons for stool retention could be unavailability of toilets. So a child who is having long car or bus rides to go to school. There could be hiking trips and camping excursions. I'm sure you can relate because many of us at some point have been constipated at some point in our lives, and the causes could look very familiar to some of us. There could be unpleasant facility. So let's say the school toilet is not clean. So the child, even though he have the urge to defecate, he doesn't dare to do it because he doesn't feel the toilet being clean enough. It could be embarrassment or lack of privacy. It could be inactivity. It could be dietary factors, consumption of constipation foods or inadequate intake of liquids, dehydration. It could be use of constipating medication. Could be rectal or anal fissure, where there we would be on more medical reasons. So with stool withholding, what we need to be careful is that, yes, it could be linked to a history of constipation, but it could also very well be linked to environmental factors that could be identified in the present environment of the child, which can also be then altered and modified accordingly to promote toilet usage and decrease the stool withholding behavior. So stool toileting refusal and stool withholding are also linked to each other and associated sometimes. So children with stool toileting refusal whose parents did seek intervention, 79% also had stool withholding. This could potentially lead to constipation and delayed training. And stool withholding behavior can lead to fecal impaction. The fecal impaction is actually the presence of a large fecal mass in either the rectum or the abdomen. And what happens is when we're talking about impaction, the stool has become very big. And in most of the cases, there is a need of medical intervention to take out the fecal impaction. Also, another thing we need to know while we talk about constipation and functional constipation and fecal incontinence is that constipation can induce urinary symptoms. What can happen is that constipation may exacerbate urinary symptoms in children with enuresis, and the impacted stool in the rectum compresses the bladder and reduces its functional capacity, and it can provoke earlier sensation to void. So what may look like as a urinary accident could actually be associated with constipation. That's another thing that we need to keep in mind. So I'm going to make a summary of all the medical terms so we can do a quick revision before we move forward. So we said constipation, and we are sticking on the conventional definition. Constipation is frequency and or difficulty in defecation for 2 weeks or more. Functional constipation is when an underlying organic cause is not identified. Functional fecal incontinence is the loss of stools in places inappropriate to the social context at least once per month in children with a developmental age of, actually it's younger than 4 years old. Functional retentive fecal incontinence, it's when there's retentive behavior, but there is no constipation, but the incontinence is not induced by the mechanism we explained earlier. I got bugged. Functional retentive fecal incontinence is when there is retention, when there is constipation, and actually the build-up stool is causing leaking and incontinence. The non-retentive kind is when there is no retention and no constipation, and the loss of stool is present, but there is no signs of fecal retention or constipation. Stool toileting refusal is when the child refuses to go to defecate in the toilet, but he can defecate in other places than the toilet for a period longer than 1 month after achieving bladder control. And stool retention is when the child withholds defecation when the urge to defecate is present. So it takes time to get it all in. That's why you have the handout. You can go and revise, relook the definitions to figure out in which cases you're actually on when you gather information. Primary and secondary corpus is when primary, the person has never mastered bowel control, as secondary is when the person developed incorporaces after having mastered bowel control. So knowing all this information and looking at the different experiences I had, I created possible subgroups. We may be in a situation where the parent reports stool toileting refusal, but there is no retention and no constipation. I color-coded it. Here we're on the green side. That means we can actually go proceed with a toilet training procedure without medical help or treatment sought. It could be a stool toileting refusal behavior, but with retention. We know the child can withhold, but no constipation yet. Here, we are in a more delicate side. Actually, we definitely need to plan for the risk of the development of constipation during toilet training. And also, if the retention is present frequently, we may need to go and start contact with a medical professional. Sometimes what I do is that when some red flags are present, when I'm on this yellow side, not only for medical purposes, but also because it's very relieving for parents to know that we have a backup plan, we'll go and initiate an appointment with the medical professional, telling them the situation and why we think the toilet training procedure needs a backup plan for constipation, to have a prescription for a laxative in case we confront constipation at some point during toilet training. Then we could be on another scenario where the situation could be there is stool toileting refusal and constipation symptoms present. Then it's the case we are on the red zone. We have to proceed with medical referral first. We could be in a more serious situation, meaning the parent could come up and say, hey, my child has already encopresis, he has fecal incontinence, and is constipated. Then we are on the red side as well. Here, medical treatment first and collaboration with the medical professional is a must. And then for functional non-retentive fecal incontinence, it's in gray because it's a gray and shady side. Here, there is no organic causes. There is no underlying constipation situation that has been identified. And we don't know why the person is not able to attain bowel movement control. Most of the time, it is linked with a developmental disorder. And usually those children have also difficulties with urinary control. So all these symptoms could be occasional or chronic. As long as we are on the red or yellow side, even if it's occasional, we should proceed accordingly. The yellow side is medical referral for a backup plan already laid out for the toilet training presentation is to consider. And on the red scenarios, usually the situation is already chronic, unless the constipation has started just recently. So I'm going to look at the questions. If you have any, you can shoot them now. Okay. Perfect. So now we'll talk about early detection and medical treatment guidelines. Why early detection is important. In patients referred to pediatric gastroenterologists, a delay in initial medical treatment for more than 3 months from symptom onset correlates with longer duration of symptoms. And when we talk about longer duration, you will see later on that we are talking about treatments that can last for months, sometimes years. I'm sorry. Children with early age of presentation, so younger than 4 years old. So now presentation, remember that was when we see the gastroenterologist, not the primary care physician or a pediatrician or any type of other specialist, associated with fecal incontinence and history of longer duration of symptoms, more than 6 months. Usually treatments have poor outcome. So delay in treatment, defined as time between age at onset and first presentation at the Department of Pediatric Gastroenterology, is negatively correlated to recovery. So if we are professionals who are working in toilet training, it seems essential that we could be very alert about those red flags. What are the prognostics of functional constipation? Among patients referred to pediatric gastroenterologists, 50% will recover and have more than 3 bowel movements or 3 bowel movements per week without fecal incontinence and be without laxatives after 6 to 12 months. So this is important to note because usually there's this misconception that we get constipated, we take the medicine, but we take it 1 time, 2 times, or a week, and then we don't take it anymore. And this misconception exists throughout. Actually, anyone, maybe a person who is not really familiar with all of this could think it works that way. And most of the time, parents also think it works that way. So usually parents, when they come and consult, and when we ask them, have you seen a doctor? Many of them had already seen a doctor. Have you been prescribed a laxative? And many of them will say, yes, he gave me this medication. And then when I say, then how did it go? Usually the answer would be the stopping of the medication very early as 1 week. Or the parent will say, well, I tried 3 days, my child didn't want to take it. And when I say, well, then the medical professional, did he come back to you? Was it a monitoring system put in place? Usually those systems are lacking, and parents go with prescribed medication without really knowing how long it may take. And when we are in a case of functional constipation, it can take very long. So to go a little more on the data, approximately an additional 10% are well while taking laxatives, and 40% will still be symptomatic despite the use of laxatives. And a total of 50% will recover after 5 years of medical treatment, and 80% will recover after 10 years of treatment, with the vast majority of patients no longer taking laxative at the end and without having fecal incontinence. So it's a very long working process, and parents need to be prepared for it when we present the toilet training program. So this research was done in the United States, and it was an anonymous questionnaire that was distributed to pediatrician and pediatric residents, asking them questions about how knowledgeable they were. NASHPANGS is the National American Society of Pediatric Gastroenterology and Hepatology and blah, blah, blah. And this is a national association who is providing guidelines and who are updating them actually quite regularly for managing functional constipation in young children. And the results of this research actually showed that 84% of the pediatrician or pediatric residents reported being unfamiliar or slightly familiar with the guidelines managing functional constipation with children. And in the time between onset and referral to a specialist, functional constipation is often managed incorrectly, even though a referral was made to a medical professional. So we keep it in mind. So now, how this information can help us. actually, what really you need to know when we work in this situation where the child has a functional constipation situation, condition, we actually need to go and look for the medical treatment guidelines for functional constipation to make sure that we know how it's supposed to work, and to collaborate with the medical doctors as well, to see if we need to look and search for another medical professional who could be more aware of those guidelines. And actually, they are very easy to read, even though they are, it's a medical publication. So you can access it online for free. So that's quite easy. So one thing that I wanted to mention, because sometimes parents will come back from a medical consultation with some treatment, and I think it's important for us to know how the treatments could be different. There are actually 4 different types of laxatives that can be used. There's only one that's recommended in the childhood constipation situations, but my goal is not to go in that details about the whole medical treatment decisions that are not really are. But I think it's important to know that there are 2 types of treatments that can differ on how it can impact and what the results could be at home with the parents and around the child. So disinfection treatment is when a regimen to disinfect the rectum before beginning maintenance therapy, or it could also be in cases where there is an infection and that there is need to a medical intervention to take the infection from the rectum. The maintenance treatment, on the other side, is a laxative. Those can be laxatives which are given regularly and adjusted to achieve soft daily stools. For most children, the maintenance regimen consists of daily doses of an osmotic laxative. If you want to know more about the names, go look at the guidelines that are on the previous slides. And usually the maintenance treatment is actually the base of the medical treatment for functional constipation. The disinfection treatment could be here for backup. Let's say, despite all treatments, child has an infection. Yes, disinfection treatment could be advised by the medical professional, but the base of the medical treatment is actually a laxative. It's maintenance treatment that's gonna be taken daily and throughout a long period of time to achieve medical success and medical outcomes. So other key medical informations that we need to know or is good to know is that maintenance treatment should continue for at least 2 months once we know there is functional constipation. All symptoms of constipation should be resolved for at least 1 month before discontinuation of treatment. Obviously, we're not the ones prescribing medication, but it's important to have that information when we have parents in front of us who sometimes could be hesitating or reluctant for a maintenance treatment. If we don't know what our attitudes should be when they share their concerns, we could actually lead them in ways that are not that will not promote positive medical outcomes. Also, another good thing to know is that the treatment should be decreased gradually. This is not the type of treatment where we take it and we stop it brutally. The treatment should be put in place, the right dosage should be found, then things should start working properly. It should be taken for 2 months. 1 month after no more constipation symptoms, it could be decreased gradually with, of course, the guidelines of the medical professional. But parents need to be aware of how this medical component needs to function and be put in place. And in the developmental stage of toilet training, medication should only be stopped once toilet training is achieved. So now we know that if we are working on toilet training with a child who is 3 years old, who is having treatment for functional constipation, we know that the treatment needs to stay until toilet training is achieved, at least, and then following the points that are mentioned above. The routine use of an intensive behavioral protocolized therapy program in addition to conventional medical treatment is not recommended in childhood constipation. Why am I saying that? And why did I put it here? Just because it's published, and it's published with by the European Society of Pediatric Gastroenterology and Hepatology and Nutrition, and also the North American Society for Pediatric Gastroenterology. What I am taking from this message is that the intensive behavioral treatment that we know as rapid toilet training, yes, it is not actually very adapted or very applicable to the situation where we encounter functional constipation. The whole process should be different. And even though there are some common concepts that should be integrated in the toilet training program. And of course, it's never fun if we don't have two articles who says the opposite things. There are also some researchers saying that there is some evidence that behavioral intervention plus laxative therapy, rather than laxative therapy alone, improves continence in children with functional fecal incontinence associated with constipation. So effective treatment of constipation may decrease incidence of late toilet training, and it's important to convey this message to parents. Now, we're going to look for consideration at the onset of toilet training for behavior analysts, and I'm going to go a little quicker because I realize that it's almost 9 p.m. or 8 p.m. where you are. We're already almost 1 hour ahead of the presentation. So what should be our considerations? First of all, at the onset of any behavioral intervention for toilet training, use the Bristol scale to identify actual and usual stool consistence. The Bristol scale was one of the best discoveries I made in my life. It's actually a very simple tool, very objective, which can give us an idea if the stool is normal, if the person is slightly constipated or very constipated, if it's lacking fiber, if there's an inflammation problem or inflammation and diarrhea, just by looking at the form of the stool. So this is very easy to use, and there is no failure. Parents can use it, other professionals can use it, and it gives us a quick snapshot of about the current situation. Take baseline data on how often usually the child has a bowel movement. Remember, decreased frequency can be a red flag. Collect information on prescription drugs and self-medication taken by the child. Check the side effects and rule out drug-induced constipation. Collect information on recent and upcoming environmental changes that may have an impact on toilet training or on the overall behavior of the child. Collect information on eating habits, fluid intake, and physical activity. There is a decision tree that you can find. Since we are missing a little bit of time, I'll let you look at it later on your own time. You will see the link to access the decisional tree is here under the second slide. It's accessible online. And even though there are some suggestions for what the education component could be, I also put individuals toilet training program that can be also adapted, but it could give you a line of decision making when you are in a situation where child has hard, dry stools that are difficult or painful to pass. It will give you an idea of what to do and when to refer. So, the behavioral treatment directions when bowel movement difficulties is or were ever present. First of all, we need to have contingencies for defecation position and regular toilet sittings, ideally after each meal. Depending on the child, that could be too much. For a child, for example, who has already mastered voiding in the toilet, sitting 3 times a day for longer periods for a defecation that only happens, let's say, every other day could be inappropriate. But to start, we can start with that. And once we have regular bowel movements and we have some indications on where it happens usually, then we can schedule toilet sittings that are more appropriate to the routines of the child. And certainly we shouldn't put lots of toilet sittings. Sometimes I see protocols where the child needs to sit first 5 minutes and he needs to come back in 10 minutes to sit 10 minutes and then again to sit 15 minutes. That's not going to help. Contingencies for daily adequate fluid intake should be put in place. Contingencies for daily adequate fiber intake and contingencies for daily, weekly physical activities. Actually, those are important environmental factors that could have an impact on functional constipation. I know we behavior analysts love precisions, so I'm going to go with precisions on these recommendations. So what's the ideal defecation position? Here on a visual, it's more a sitting that looks like squatting, and ideally with 35 degrees between the upper body and the thighs. If the child is sitting like this or is having any other posturing that are very different than this one, then we should probably shape and reinforce the ideal defecation position. What is adequate fluid intake? Here is a table showing you what is the ideal fluid intake by day and by age that you could definitely incorporate in your toilet training program. What is adequate fiber intake? And the same here, you have, this is here, this is available online as well. So if you need to reach the original document, but otherwise, here are the daily intakes, ideal daily intakes of fiber in grams according to the age and the sex of the child. And we need to plan to increase physical exercise. Unfortunately, many of the children that we work with sometimes don't have access to physical activity very often or as frequently or as long as they need to or they should to. And here are some key guidelines on what is recommended physical activity for preschool age children. What's recommended is physically active throughout the day. For school age children, it would be 16 minutes, so 1 hour a day or more for moderate to vigorous physical activity daily. And with children with special needs, when it's possible, those children should meet the key guidelines. But when it's not possible, they should be as active as possible and avoid being inactive. Also, another thing that we can see in research is that there's one research, and I think there are multiples of them, where they measured the impact of using positive terms for stool and how it could help shorter the duration of toilet training. So this is a suggestion. Why not? I mean, it's good to use positive terms about stools and defecation, and also removing negative attributions to stool and accidents when the child is actually medically not ready to be successful to have bowel movement controls. So now I'm going to present some cases. Do you, before I present the cases, because we're, do you have any questions? Or did I lose all of you? Because I had a lot of questions at the beginning and now I don't have any. So maybe there were too many medical terms used. A quick feedback before we proceed. Yeah, that's what I was wondering. Are you guys still here? Okay. Okay. Okay, perfect. All right. If it's because everything is clear, that's relieving because, okay. All right. So we can go over the cases. Okay. Thanks for the feedback. Perfect. Jasmine, did I answer your question? Ah, here you go. I have some questions. Perfect. I love questions. What are some positive ways of speaking about tools? You can go as creative as you can. I got parental report about like, oh my God, how handsome is your stool? How beautiful is your poo? I love your poo, and things like that. Or something that the parent or you may find more appropriate than this. So it's very, it can be individualized to the family, I believe. Thanks, Meral. What are some positive ways of speaking about stool? Sorry, I think I more answered one question by mistake. Is it appropriate for laxative to be used weekly for stool retention? Is a laxative helpful in that instance since the child is withholding? So usually when we use a laxative because the child is withholding and once a week, it will be more of a disinfection treatment. In one of the cases, you will see that's actually the preference of the mother, but it's not really recommended. It can be used if there are going to be a few instances when we will need to do the disinfection to create the defecation behavior and reinforce. And let's say if we did this 2 or 3 times and we got results, it could be okay. But if it's a continuous treatment that is done every week and for too long, so more than a month, for example, that's not the appropriate treatment. Also, we could look at how constipated is the person. Is it just retention, and is it only used for the retention behavior, or is it used because the child has impaction? That question is also important. But just keep in mind that the base treatment, if there's really functional constipation, is maintenance treatment. It's not disinfection treatment. Could the whole body stereotypy, stamping the feet on the floor and concurrently hop be an indication of physical exercise? I would suggest to go and look at the resources I shared. Those were actually guidelines for healthy eating habits for Americans. Even if you're not Americans, attention, but they actually put a lot of efforts in this document to specify and really go into details on what physical activity could be considered appropriate and along with the guidelines. So I would refer back to that document and see if those indications there help you get an answer. Is it appropriate for laxative to be used weekly for stool retention? Withholding. So I think that we answered. And is a pediatric gastroenterologist recommended in this instance? Which instance? When there's retention? I think, Jasmine, at some point we'll get your case because I feel like you have a lot of questions and a specific case for which you're asking the questions, and I don't feel like having the complete information. If there is a conflicting medical condition such as chronic constipation, which postpones behavioral toileting intervention, how can we best support the patient and family while we wait for the course of the medical treatment to be completed? Okay, we'll talk about it in a little bit. What about a child who is on a regular schedule for defecation, however, will not sit on the toilet to do it? Parents also don't make the child sit because he gets upset, but the child will ask for a diaper and immediately defecate in the diaper. Urinary is under control. Perfect definition of stool toileting refusal. So there is functional constipation present or not, Justina? You say if there is a conflicting medical condition. So that means there is functional constipation, chronic constipation, no medical condition. Okay. Okay, so let's go over the cases, and I'll come back to your cases if your questions are not answered in there. So here are different cases, which some of them are very similar to the cases you mentioned on your questions. Case 1, this one is a very easy case. A 7-year-old boy with ASD, he has defecation 4 to 5 times per week, and they're beautiful type 4 poops. So no constipation, red flags. He's toilet trained for urination and goes to the toilet to avoid. He asks for a diaper when he feels the urge and defecate in it in different places in the house, but not the toilet. The parents are afraid to refuse access to diaper because of a history of constipation. This is very frequent. They also think he has a hard time terminating a pleasant activity to go and defecate in the toilet. No prescribed drugs or self-medication are in place at the onset of the case. Here are the interventions and results. When we look at the key information, he has beautiful stools. He has frequent defecation. He has a history of constipation. We take note of that. He has good voiding urination control, but he's defecating in a diaper. So when the situation is like that, you can actually go ahead and prepare the family to remove access to the diaper and the child by providing him wordful contingencies. So we did have a collaboration with the pediatrician to prescribe a laxative in case after the onset of toilet training treatment constipation occurs. Because parents' hesitation is actually really important, because if parents are not ready to follow up with treatment, we can forget about it. So sometimes actually we'll go see the medical help just to make sure we have a plan B and everyone is relieved and ready to proceed with compliance with the medical and behavioral treatment. We put in place a toileting diary. We put in place protocol to increase fiber and fluid intake and physical activity. Parents got lots of information about those hygienic and dietary factors. We removed access to diaper. So there was no diaper. Even if he asks, there's no diaper. Extinction. The medical doctor actually prescribed a fast-acting laxative, and the mom used it 2 times where she felt that the child needed a bowel movement but was having some difficulties. And behavioral treatment was closely monitored. Within 2 weeks, the client was toilet trained. This is an easy peasy case. There is no constipation. There is type 4 poop. Frequency of constipation is more than perfect. So now let's look at a different case where the situation is different, is a little bit more critical. 30-month-old boy with ASD with a diagnostic of encopresis. So he's already having fecal incontinence when mom called me. Mom wants to start toilet training. The child doesn't want to wear diapers, but have no successful elimination when it's taken off. He was not voiding in the toilet, no successful urinary elimination, and neither defecation. In the past 6 months, he started having fewer bowel movements. First, it was 3, 4, once every 3-4 days. Now it's every 10 days. Child is reluctant to take daily laxative treatment, which was prescribed. Parents administered it for 7 days. They observed no progress, so they stopped. When it has been too long without defecation, parents notice behavior agitation and walking on his toes, holding onto a furniture and squeezing his buttocks. Defecation and urination happens in places other than toilet. Parents sometimes take off the diaper to see if he can start toilet training, but he doesn't want to sit on the potty. Parents started toilet sitting 2 times per day with no reinforcement contingencies, just explanations on how it can hurt less if he eliminates more frequently. Parents reported the presence of fecal liquid that looks like diarrhea. So that's the red flag for fecal incontinence induced by constipation. And everything started 6 months ago after a period of acidic diarrhea during which the child looked in pain. Parents have just arrived from a long trip. No prescribed drugs or self-medication were in place at the onset. So here you see we're already on the severe side of the constipation problem. So first, the intervention was toilet training on hold. Multiple reasons were there for it. You are just coming back from vacation, and the child is definitely not ready, medically speaking, to start toilet training. Referral to a pediatric gastroenterologist, and during our first phone call conversation with this mom, I had to tell her that a laxative treatment for functional constipation is not 7 days. It is a lot longer than that, and it should be decreased gradually once the child has a frequent bowel movement and soft stools. So she was already a little prepared to what was coming next. Baseline data on stool frequency and using the Bristol stool scale. Introduction of the concept of reinforcement and making the mom discover the power of reinforcement. Encouraging toilet sittings with pairing and reinforcement. So there we were really working on the duration first, and all we wanted was that he sits after each meals and that we increase the duration, but no other expectations than that. No contingencies for unsuccessful elimination in the toilet. Protocols to increase fiber and fluid intake and physical activity. Toileting diary. So that was like the first plan. Once mom discovered and the child discovered the power of reinforcement, actually the child has mastered voiding skills in 2 days after reinforcement was introduced for toilet sitting routines. So that was amazing. And the mom was really surprised too. But first, the duration of sitting was reinforced, and we don't really worry about anything else. Then tempting to eliminate while successful elimination was reinforced with a higher valued reinforcer. That means once the child was able to sit 5 to 10 minutes and he mastered that skill, we were reinforcing tempting to defecate, to eliminate. But if there was a successful elimination, he would get a more highly valued reinforcer. After regular bowel movements were achieved, the frequency of defecation was reinforced only, but that's like later on after 1 year or 1 year and a half of treatment. Relapse effect was closely monitored. Early fading of medical treatment or early fading of reinforcement and changes in environment, for example, when he was having sleepover at grandparents, were identified as primary factors for relapse. So anytime we were trying to, the parents were trying to fade a little bit the medicine or the reinforcement, we could have relapse effect. And then we'd go back to previous, previous parameters to fade on later. The school was also aware of the treatment and provided reinforcers according to the current protocol or to the current protocol in place at that time. Maintenance medical treatment and behavioral treatment was maintained for 2 years long. Behavioral treatment was also maintained for 2 years. Fecal incontinence was treated with success, and the child now can have occasional constipation, which is treated right away, but he has no more fecal incontinence. External reinforcers are not used anymore, and child has achieved toilet training after 2 years of a medical behavioral treatment and with close monitoring. So this is amazing success story, and actually this is a case that helped me a lot to learn about functional constipation and many of the things that I am bringing today. A third case. Here, the situation is a little bit more different. The child is already 12 years old. He can void in the toilet since 3 years old, but only at home. He does not defecate in the toilet. Until the age of 2, the child was having frequent stools, type 1. So the type 1 is where we are very constipated. After 2 years old, it became more complicated, and now he has frequent soiling or fecal incontinence 5 to 6 times per day. And he's going to college. He was going to college. He's still going. Since 3-4 years old, he was having those fecal incontinence episodes daily. He was using a toilet seat that dad decided to take away recently. So now he refuses to sit on the toilet without it. He was prescribed a laxative years old by a child psychiatrist. I put the names of the laxatives. You can look at it if they're appropriate or not. He has bowel movements in his room, in his underwear, some evenings. Those are usually hard stool with a large diameter, but he doesn't have stools in the toilet. When he needs to defecate, he engages in retentive posturing behaviors. The current contingencies at home are, if anything drops in the toilet, the child can have the iPad. So at this time, there was no prescribed medication and no self-medication either. But as you can see, we are on a very severe case with very little, with a lack of medical intervention that was existing since a very long time. So first stage, referral to a gastroenterologist who prescribed maintenance laxative, but also a biofeedback treatment. So I participated in the biofeedback components, and I tested how we can use a token economy to actually see if it could even be more helpful in trying to teach him to squeeze and relax. And the biofeedback treatment is actually the child. Some electrodes are put on his anus, and those electrodes help to identify when the muscles are squeezing and relaxing. And we are working on a video game where when he's doing the right thing, actually there's like a guy who's looking like Super Mario who's getting some mushrooms on the sky. And at the beginning, it was kind of hard for him to follow that. So we did use a token economy to reinforce when the approximations and when the guy was getting lots of mushrooms on the screen. Scheduled toilet sitting after each meal and reinforcement for duration, protocols to increase fiber and fluid intake and physical activity, and a toileting diary was put in place. Unfortunately, this case, we did started things with the mom, and I did make the whole collaboration with the medical professional at the first place, but then I had to stop this work with them, and after I called them for a follow-up interview, here is the information I got. So today she's actually using a disinfection treatment 2 times a week. The mom doesn't want maintenance treatment, and she stopped it after a week because she fears that the child may have an urge to defecate at school. She had follow-up consultations with gastroenterologists every trimester. No more records of hard stools with a large diameter are present, so that's a good thing. The child continues to defecate in underwear and very rarely in the toilet. Mom reports less frequent soiling, more like traces before a bowel movement, and not like diarrhea looking like fecal incontinence symptoms, and is satisfied with current progress. Nevertheless, she'd like to resume behavioral treatment, and I'm going to start work. I'm going to go back to this case very soon to go over the current situation and propose a new protocol. So the take-home messages for behavior analysts, what I'm going to do is pretty much those are just information I gave throughout the presentation, so I'm not going to read them out to save some time for questions.
Nursel,
yes.
Can I say thank you very much for an excellent presentation? This is such an important topic, health-wise, and you've given us very, very good ideas on how to put in place some of the strategies that you've described in very much detail. Can I make one? As we're coming to a close, we only have a couple of minutes, so I have one question, and then I'll let you answer any questions within the time, if you have time for more questions from those published.
Yes.
But if there was one single tip for us to take home, what would you suggest that we should do when toilet training to prevent bowel movement difficulties? So when we start toilet training with very young children, either typically developing or not typical. So thank you.
So the general strategies, we will go back to hygienic and dietary factors that we mentioned. Fluid intake, fiber intake, physical daily activity is very, very important. Another thing, the whole strategy of talking positively about stool is also important. General wise, so not using statements like it's dirty, it's disgusting. Some research also suggests allowing the child, even though he's not at the age of toilet training yet, to see parents using the toilet. So it becomes something that he becomes familiar at a very early stage, even though we're not at all ready to start toilet training, just to make sure that the child is observing those moments, that it's not taboo. And if he wants to once in a while try to sit or something on the toilet or something like that, encourage those type of behaviors. Those are general guidelines for the children who are younger, and even if they're not ready developmentally yet for toilet training, these are the things that we could watch and do to avoid any possible future risks. You're welcome.
Very much.
I would like to talk about this last slide because I was really happy. As you can see, the cases, they are long intervention, and it's really hard to sometimes record data and analyze them in the way we do in ABA. So I just discovered while preparing for this presentation, when I looked to see if there was anything new on the subject, this research article where multiple teams around Europe and the United States developed a very quick and easy questionnaire. There are only 6 questions, and actually it helps us to see how good is managed constipation in pediatric patients. So I got in touch with the authors, and they allowed me to share with you the second PDF document that you will find on the next to the handouts. Feel free to use it. This is a questionnaire the parents could, or the child could answer, and the score can give us an indicator on the long run of how good we managed constipation with children. So the indicators are quite interesting, and in cases like the third case where I showed you, where the mom is actually, when I had her on the phone, she was really happy with the progress she made, because I left her alone for quite a time I didn't supplement with continuous behavioral strategies, at least, but she had medical follow-ups, but she was happy. And if we look at the data, and if we were to evaluate the outcome of the medical treatment that was put in place, and if we were based only on increasing defecation in the toilet, we wouldn't see any progress. But if we did provide that questionnaire to the mom like 4 years ago, and I'm sure if we did provide it today and looked at the results, we would have seen how good was it managed? Was it poor management, good management, or etc. And we would have more indicators about this mom's current satisfaction. Voilà. So thank you very much for your attention and for all your comments, positive comments, for your questions. Happy Women's Day to everyone also. This is a pleasure to present on Women's Day. If we can be allowed to go over the question and have 15 more minutes, I would be happy trying to answer the questions.
We thank you very, very much for such a long seminar. It's clear that you're devoted to what you do, that you love what you do, and you know very well the research around this topic. So I think it's time for the webinar to end, but okay. I propose two things. First, anyone with more questions could email you. Your email is on the last slides.
Yes.
Could email me or Carola, and then we can, get them in touch with you. But I think getting in touch directly with you would make more sense. And I also, we can have you for another talk. We can have you for a more hands-on or more practical session at another time.
Of course.
Because we've all loved the contents of your presentation, so we can keep some of the interest of the audience for maybe another talk. So that today's doesn't, become very, very long. Is that okay?
Of course, with pleasure.
Okay, so thank you very much again.
You're welcome. Thank you for your attention and all your positive feedback.
So have a good night to everyone. And remember, Nursel's recording will be made public on the Center for Behaviour Analysis webpage under resources. So have a good night to everyone.
Good night,
Bye.
everyone.
Bye.